Cancers or cancers of the colon and rectum are ever increasing in our population. As the GDP grows, as we industrialize more, we only get more colorectal cancers. The age seems to be reducing as well, where we often saw patients only in their 5th, 6th, 7th decades and beyond get colorectal cancers. We now have younger patients who are in their 20s, 30s, and 40s getting colorectal cancers, as a colorectal surgeon would say, is amongst the better cancers one could get if they had an option, if that makes sense, because these are treatable and they are curable. It essentially needs to be diagnosed at an early stage so that patient education is key. The symptoms of colorectal cancer are rectal bleeding, which is the most important symptom. Unfortunately, what happens is rectal bleeding is often ignored and are often attributed to other benign conditions such as hemorrhoids, fissures, and fistulas. When a patient presents to a colorectal surgeon with any of these above symptoms, the first thing that a colorectal surgeon does is to ensure that they don't have any red flags for colon or rectal cancer. This can be by a detailed clinical history, a rectal examination, or a sigmoidoscopic evaluation that can be done in the clinic itself. What I tend to do with my patients is that I make sure that I counsel them adequately and they understand the value of having a colonoscopy at the earliest if they have any of the red flag symptoms. With the colonoscopy, we are able to identify and diagnose cancers, and we will even be able to prevent cancers from happening by picking up polyps earlier on in the course of their journey. With colorectal cancers, there is that advantage of lead time where we can catch a polyp before it becomes a malignant lesion, and we are able to treat patients endoscopically without the need for an operation itself. When these patients eventually progress and do have colorectal cancers, our treatment options have improved tremendously over the period of the last few decades. We've now got standard SOPs for the treatment of colon and rectal cancers. Patients with colorectal cancers need an MDT approach because they will end up receiving a combination of variety of treatments that can range from chemotherapy to radiotherapy to surgical treatment and to immunotherapy as well. With recent advances in the management of colorectal cancers, we are able to offer much better collaboration between other medical professionals so that a patient gets the best possible outcome for his or her cancer. The staging of colon and rectal cancers often involve a CT scan at the very least to stage the chest and the abdomen. Patients of rectal cancer will definitely require an MRI as well to stage local disease in the rectum. Most patients who have locally advanced rectal cancers will often receive chemotherapy and radiotherapy at the outset. Now, this combination therapy can be delivered in two ways. We can offer them treatment as what is short and long course chemoradiotherapy, and the choice really depends on what the surgeon and the specialist team feel at that point of time is more suitable for your care. But it would be helpful if a patient understood that there are these options as well, so that they can make an informed decision. The treatment of colon and rectal cancers have changed significantly since the evolution of the MDT, where we are able to make combined treatment decisions for the patients that we have. With the evolution of surgery that has moved on from open surgery to laparoscopic to robotic and even more minimally advanced techniques via the transanal routes, we are now able to offer amazing results to our patients simply because we send them home much sooner. The shortest patient I've had stay under me after having undergone a laparoscopic operation for colon and rectal cancer is 2 to 3 days. This is a large divergence from the past where we had patients who would stay in hospital for weeks before they could be discharged. We've now incorporated the principles of enhanced recovery after surgery as well into our practice, whereas we don't starve patients before their surgery for prolonged periods. We in fact load them with carbohydrates and proteins so that they have better outcomes. And with better developments in mechanical surgery, we've got better staplers, better guns that we use for surgery, as we call it, and patients have much better results. I often tend to get my patients out of the bed at the earliest possible time, potentially the first morning after the surgery, get them to mobilize, get them to bathe, get them to shower, and so they can feel good about themselves and be part of that recovery as well. This early mobilization and early recovery, where a patient takes ownership of their own health, helps play a significant role in their recovery. At our institute, with the colorectal cancers, we've set up this world-class MDT that uses cutting-edge technology and also evidence-based practice so that a patient with colorectal cancer can live a full life, because colorectal cancers are treatable and curable.